You are in the meeting now. Hey, Justin.
Morning, Jason. How are you?
I'm good. How are you?
Good, good, good.
Do you want to test things out, make sure it works?
For sure. I'm just trying to find the shared screen option here.
Should be at the bottom in the middle.
Does that look okay?
Yep, that looks good.
Perfect.
We'll probably start like maybe 2 minutes or 3 minutes after 7:30.
Yeah, no problem at all. Sorry, Jason, a quick check. Do you see my mouse cursor or no?
Yeah, I see it.
Okay.
Dr. Spangel, can you mute your phone? Thank you. We're going to give people just a couple more minutes to shuffle in. Okay, I think we're going to get started. Thanks everyone for coming to Grand Rounds today. Today is actually the last of the Grand Round sessions for this academic year, and we will reconvene for the next academic year starting just after Labor Day. So thank you everyone for participating over the course of the year this year. Just a reminder for today to please turn off video and mute your microphone during the course of the talk, and feel free to ask questions towards the end. A reminder to please submit your attendance and evaluation forms, and especially now when we're planning our academic program for the next year over the summer, please write down any ideas for topics that you would find interesting, and we'll definitely add them to the list for the upcoming year. On that note, I would like to introduce Dr. Justin Mui, who's an obstetrician gynecologist at Surrey Memorial with expertise in advanced laparoscopic surgery. He's a clinical assistant professor for the University of British Columbia and an active member of the Department of Obstetrics and Gynaecology at Surrey. His clinical interests include ambulatory surgery and minimally invasive surgical approaches. His practice focuses on abnormal uterine bleeding, fibroid uterus, endometriosis, chronic pelvic pain, infertility, and consultative obstetrics. And Dr. Mui today will be giving us a talk on laparoscopic abdominal cerclage, which is very interesting. I'll leave the podium to you, Justin. Thank you very much.
Thank you, Jason. Thank you for the great introduction. This is a topic that I have great passion about, and I'm excited to share with you some of the pearls I've learned over time, and also some of the more recent findings in terms of evidence supporting or refuting laparoscopic abdominal cerclages. So I'll just jump right in there. These are my disclosures. Some of the objectives I wanted to cover today were just to kind of explore and introduce the issue of cervical insufficiency and pregnancy in general. I wanted to touch base on some of the treatment options for cervical insufficiency, some of the evidence, recent evidence and outcomes of a cervical cerclage, and then moving into exploring abdominal cerclage and touching base on laparoscopic cerclage for refractory insufficiency. And then I did want to spend some time also talking about the actual surgical technique and approach. I have a few videos to share as well, and I hope that these pearls can be taken up by some of the audience today. So cervical insufficiency, defined by our colleagues down south, there is really the inability of the uterine cervix to retain a pregnancy beyond the second trimester in the absence of labor. It's not a very common problem that we face, and it can affect up to about 1% of pregnancies. However, when we're dealing with consultative obstetrics, it can be up to 8% of things that we see for things like recurrent second trimester loss. So it does not infrequently come up in our population. And it is one of the major contributors of preterm birth and associated morbidity and mortality in this population. And as we all know, neonatal morbidity is inversely related to the gestational age. And unfortunately, cervical insufficiency really is one of those issues that comes up at that very precarious gestational age where we're talking about preterm birth. So the causes of cervical insufficiency, it can, the thinking is that it's either a functional or structural deficiency, and it really kind of leads to things like infection or inflammation. And the sequential depiction of it on ultrasound is this TYVU progression that we often hear about or see. In the top left corner, represented by T, is kind of our normal cervix. Then we get into the Y, where we get a little bit of beaking, and then further beaking into funneling, and then persistent funneling with the short cervix at the very end. When we talk about risk factors, we're really talking about two main things. One is prior history, like many obstetrical conditions, so mid-trimester loss or preterm birth, previous early rupture of membranes, or a detection of a cervical length that's short less than 2.5 centimeters before 28 weeks. And the other category we really look at are structural things like a previous history of cervical trauma or leak procedures, uterine anomalies, twins, some would argue, increased BMI as well, and then the integrity of the cervix itself related to connective tissue disorders. In terms of diagnosis itself, there's kind of two ways to look at it. One is a more prospective, the other is retrospective. On the prospective branch, we're looking at things that we find on physical exams. So these are the patients that come into triage, and they come in with a bit of vaginal bleeding or discharge. You do a physical exam, you do a speculum, and you see prolapsing membranes. So that's where you make one of the diagnoses. The second way a diagnosis could be made is via ultrasound. So that's where you have a less than 2.5 centimeter cervix before 24 weeks with the history of preterm birth. And given that, diagnosis of a cervical insufficiency can be made. And the last way we could take a look at diagnosing these presentations is through history, and this goes back to our definition, a second trimester loss without any presence of labor. When talking about management for cervical insufficiency, there's kind of two arms. One's a medical arm, mostly talking about progesterone treatment. The other one is the cervical cerclage. So the two approaches that have been long-standing. What's very interesting is that there are some studies that have been performed, but they haven't really shown that either one is more beneficial than the other. But the caveat also is that there has been no head-to-head comparison or randomized controlled trials comparing medical or surgical for the treatment of cervical insufficiency. And then we talk about the indication. So this comes up a lot as well. How many losses before we think about a cervical cerclage or cervical insufficiency? Us here in Canada, which is very similar to our colleagues in Europe, we generally have that definition of 3 or more mid-trimester losses or preterm births, whereas our neighbor down south maybe are considered a little bit more aggressive, and they actually think about considering a cervical cerclage in those with 1 or more preterm births or mid-trimester losses. When we talk about the actual cerclage itself, the most common approach is a vaginal cerclage. It is considered a first-line surgical treatment for cervical insufficiency. And it works by, what we think it works by, providing extra tensile strength, the actual integrity of the cervix itself. And there's also a thinking that it helps to prevent membrane exposure, so therefore decreasing ascending infection that could lead to preterm birth. It's usually placed in the first trimester after pregnancy is established, and it's usually removed, near term, 36, 37 weeks prior to labor. The two most common techniques that we look at, the Sherrod-Carr on the left, McDonald on the right. The Sherrod-Carr technique is also kind of considered a high vaginal. Why that sometimes is preferred is, you can get higher on the cervix. It does involve dissection of the bladder, it does involve dissection of the rectum, and by doing so, it allows you to get higher on the cervix, perhaps to get a longer cervical length and arguably have a more efficacious outcomes compared to the McDonald cerclage. I think most would agree the McDonald cerclage is something that we see more often. I think it's also because it's used in an emergent setting. It's a little bit more simpler to perform. And there's arguable evidence as to whether one or the other actually provides more benefit in terms of preventing preterm birth. But what I wanted to head towards today really is talking about these more uncommon cases of refractory cervical insufficiency. And this is really the occurrence of a second trimester loss or preterm birth, despite the fact that we place a well-timed cervical cerclage. So despite the fact that we put a vaginal cerclage, we do get a subset of women that unfortunately do fail. So up to 15%, despite a vaginal cerclage, can have or experience a preterm birth. so what really do we do in these settings? And I think this is the crux of the topic that I wanted to touch on today, and just to go over some of those options. So option number one is a repeat vaginal cerclage. I think this is something that is offered commonly, probably because I think as surgeons we always feel that we can improve on our previous technique, but also because of the technical ease and access. I think that we're all quite comfortable in performing, cerclages. So we can, if we did a McDonald the first time, you can try high vaginal cerclage. You can, optimize the technique again. The second option that we have is an abdominal cerclage, and this is a placement of a cerclage that's slightly higher on the cervix. And the other benefit, of course, is that it avoids a foreign body in the vaginal canal. So the believers of, an ascending infection, an ISR infection, this is something that can obviate that concern. The picture I'm showing here depicting actually is one of the reasons why we feel that the transabdominal cerclage is superior, and that's really because over here in placement of the abdominal cerclage, I just want to make sure my mouse is here, is quite high. It's actually higher, the placement is higher than the cardinal ligaments. And the argument is that perhaps, putting the cerclage above those cardinal ligaments adds an extra layer of structural support. And perhaps that can be, a difference maker in terms of getting more weeks, preventing more preterm birth. And that really is one of the biggest drivers of and thinking behind why a transabdominal cerclage may be superior. So of course, with new techniques, with new approaches, there's always some roadblocks, and some of the ones that we face for sure are things about questions around surgical risks. The fact that, putting a higher cerclage that's inside the abdomen, arguably mandates a cesarean section for delivery. And then the fact that whenever there's a new procedure that's introduced, there's always a limitation in terms of objective data. Is this better? Is this worse? Is this the same? Should we continue to proceed? These are big questions that always come up, and it wasn't until recently, actually, where or I feel at least, that we have some more evidence to suggest one or the other. So that leads to one of more recent landmark studies that came out, the Maverick study. And this really tried to answer that question about, comparing a transabdominal approach or a cerclage with vaginal cerclage. And this was a multi-centered study that was performed in the UK. It allocated participants to 3 arms, one that was a transabdominal, non-laparoscopic, just to be clear, and then to vaginal cerclage, either a high vaginal or a low vaginal cerclage, equivocal to a Sherrod-Carr or a McDonald approach. So they had just over, 130 patients. 110 of those were analyzed, and their outcome measure was really preterm birth less than 32 weeks. What they found was quite interesting, and just focusing first on the transabdominal approach, you can see here that there were significant differences or reduction in preterm birth at all age categories, and the live birth rate was also higher when you compare that to the both the vaginal and the low vaginal, the high vaginal and the low vaginal cerclage. What was also very interesting was that if you take a look at the numbers between a high vaginal or Sherrod-Carr technique and a low vaginal or McDonald technique, they actually look quite similar in terms of their efficacies or their outcomes. So they had very similar rates of preterm birth and live birth rates within that population. So this study really did, was one of the first that, or is the first that has shown a significant difference in the abdominal approach, perhaps being superior in the vaginal approach, specifically in those patients who had failed a previous vaginal cerclage. So just to summarize again, they had higher neonatal survival rates in those with the transabdominal approach. The average age of delivery was higher in the second pregnancy, following the previous loss, and their number needed to treat was actually 1 in 4, which I always found this fascinating. We do a lot of different things in medicine, and some of the evidence that we have, it's interesting to take a look at some of the number needed to treat. So something that we're all familiar with, membrane sweeps to avoid, an induction labor. Number needed to treat is actually 7. And if you take a look at some of the, the medications that are used to treat things like MI or strokes, the number needed to treat actually is quite high, 20 and 67 respectively. So, I mean, a number needed to treat of 4 is actually quite low and quite significant. So the next step, of course, is, how do we marry the benefits of a abdominal approach with some of the benefits we know and have established with laparoscopy? And this is where really my passion comes in. And I feel like I was one of the lucky ones also. Some of my predecessors before me, had exposed me to an abdominal approach. I've seen them before. I've seen the struggles, the challenges of that approach. And then also on the flip side, being able to go through some more recent training and going through and experiencing the laparoscopic approach. So being able to, see and weigh those differences has been able to, it's been enlightening. So if you take a look at the laparotomy or the abdominal approach, the traditional one, it is actually a procedure that has been described, for quite some time ago. Usually what it involves is a fat instilled incision. It's usually placed in the first trimester, usually between 12, 16 weeks. And the postoperative stay could range anywhere between about 1 to 3 days, depending on usually biggest barriers for pain management. More recently, however, laparoscopic approach has been adapted. When I say more recently, it is, it has been about just over 20 years now, but it's still recent in the terms of, surgery and practice. This does require, the standard laparoscopic ports, the benefits of MIS surgery, like reduced pain, blood loss, and shorter recovery times. I would argue that there's also a reduction in operative risk, and that's really based on, improved visualization and our ability actually to move the uterus a bit better. And I think the biggest difference between the two of these approaches is that the laparoscopic approach, it allows us to place the cervical cerclage before someone actually is pregnant in. And I think that this is the biggest difference that drives the different outcomes between an abdominal and laparoscopic approach. So some other recent studies that looked at, abdominal versus laparoscopy for placement of cervical cerclage, Moet et al. In 2018, they did a kind of a pooled retrospective study. It included about 1,000 patients. And they did find a significant difference between laparotomy and laparoscopic approaches. So the survival rates, live birth rates were higher in the laparoscopic approach, and losses were lower in the laparoscopic. And their argument was that that timing of cerclage placement, pre versus post-conception, laparoscopic being pre, laparotomy or abdominal approach being post, is what makes a difference. I think that I'll get to some of the arguments afterwards, but the biggest thing is that it's, when you have an established pregnancy, it's a bit higher risks. There's more risk for bleeding. There's more risk to run into the uterines. There's more risk for, inadvertent rupture of membranes, which can all lead to, poorer outcomes. Our colleagues down in Boston, Massachusetts, they've also looked at their experience with laparoscopic abdominal cerclages. They had just over 100 patients. They had equivalent, to the previous studies of survival rates, which have been, upwards of 90%. But their big focus was really trying to highlight some of the technical surgical aspects. So they showed, very favorable statistics, like operative time being very short, less than an hour, very minimal blood loss, and instead of staying for 1 to 3 days, most of these patients were discharged home on the same day. So, lots of arguments that perhaps suggest, a laparoscopic approach would be superior to an abdominal approach, not only for outcome, but also for the time of surgery and patient experience. So with some of that background information, I did want to show just a quick clip. It's about 3 minutes long. This is some of the salient or some of the highlights of a abdominal cerclage procedure. This was actually done in Vancouver, courtesy of Dr. Niraj Mira. So let's just have a look, and I'll walk you through the approach here. So we're looking at the pelvis standard kind of view. We're working on the patient's left side. Right now, we're just working to see and expose the broad ligament and expose some of those vessels, the uterine vessels that we're trying to avoid. Here, we're working on the contralateral side, so the patient's right side. Again, just working on the broad ligament to expose the uterine artery. You'll see this come up pretty quickly, just right there, just lateral to the Maryland right there. Medial to the Maryland. And what they're trying to do here is, again, trying to isolate those uterine vessels so that you can avoid them when you place the suture. This here is the Prolian suture that's used. And again, what they're trying to do is, you can see here clearly the uterine artery that's outlined that you can see after dissection. And what you're trying to do really is just place that suture just medial to that vessel and try to avoid any injury. So this is a back to front or posterior to anterior approach with the knot tied posteriorly. So on the patient's right side, we're going posterior to anterior. On the patient's left side, we're going anterior to posterior. Again, here we're just being careful just to be able to avoid those uterine vessels. And this particular video clip here is actually also important because it shows there's a uterine manipulator that's inside the uterus right now, and it helps really to mobilize that uterus and allow for this maneuver here that you'll see, where you just kind of antivert the uterus so that you can drive that suture and needle through anterior to posterior easier. So again, because of the fact that this is a preconception placement, you can put that uterine manipulator inside. It just really helps for uterine mobility, visualization, as you can see. You can see the placement here. It kind of highlights, how we're talking about the suture being higher in the cardinal ligament, or higher and above those ligaments. We're really above the uterosacral, so you can see about 1 centimeter above those uterosacral insertion points. And then finally here, the suture is tied posteriorly, or the knot is tied posterior. There's a number of different ways. This is the sliding rotor knot, but you can also do it extracorporeal. You can do it intracorporeal. Many different ways to tie down the knot. Some surgeons also, at the end of tying down the knot, they may, mark the actual suture with a few titanium staples. I'd be interested to know. We do have a few MFM on the line here to see if that actually would help localization at all, especially if we're using a Prolian. But something I'll ask at the end here. So again, just to highlight here, this is a few pictures just to highlight some of the points. Step A, or top left picture here, is depicting dissection of the broad ligaments to help visualize the uterine arteries. This here on B, figure B on the right, top right, is really just showing insertion of the suture. Here we're using a Merceline tape, and they're going from anterior to posterior, posterior to anterior. And C, you can see how they're tying that knot anteriorly instead of posteriorly. And then finally, D here, they're choosing to reperitonealize and cover that suture material. So, going through and looking through some of the techniques and some of the arguments for when a abdominal cerclage should be placed, I think these are some of the things that, certainly I asked. And from a preconception standpoint, some of the arguments for it for preconception placement is that you have an established pregnancy, therefore you probably have lower rates of a miscarriage. You know, it allows for time for screening for things like aneuploidy. You know, you can do an NIPT or, you know, if it's available, a first trimester screen. And then you can even potentially assess for early anatomy. I know this, you know, about 16 weeks, it might be a little bit hard, but it is a possibility. So these are the things definitely, you know, would be favorable in a post-conception insertion. But I think the preconception benefits really outweigh some of the post-conception. So the things that I feel are more favorable in a preconception or before conception is established is that you know, it is more feasible to do this procedure. You know, there's easier visualization, easier manipulation, and the biggest thing I alluded to before is, you know, the risk of amniotomy and perioperative losses. You know, it's mitigated. There's no pregnancy in there. And then, you know, some would also argue about, hey, does it impact, you know, conception afterwards? And our study so far hasn't shown that having that stitch actually prevents, you know, conception from happening. When we're talking about the techniques itself, I get a lot of questions about, you know, what is used. So as you can see, I've demonstrated that both immerseline tape and Perleum are commonly used. I think immerseline tape is shorter. It does require the operator to do or perform a knot that's tied down intracorporeal. Some of the concerns with immerseline tape, it is considered more or felt to be more potentially a nidus of infection given the weave. And there have been some cases of mesh migration or migration of the stitch. From a Perleum perspective, you know, it's a longer thread. The knots can be tied extracorporeal, intracorporeal. The argument against it is that easier for knot slippage. The other technical point that I find is very important is that when you're doing an abdominal cerclage, you have to pick a large enough needle. You want to pick a needle that can traverse from anterior to posterior and posterior to anterior through the cervical stroma in one go. And really, you're looking at needles like the CT or the CTX, larger than our standard CT1 that most of us use for gynae surgeries. The other equivalent when we're talking about immerseline tapes, we're talking about the blunt point needles, and those, you know, by standard are a little bit bigger anyways. So if you're going to grab a Perleum, look for a larger needle in order to, you know, avoid those times where you try to pass a suture that, or you try to pass a needle, but it doesn't quite make it through from posterior to anterior or anterior to posterior. In terms of knot placement, anterior, people would argue that it's probably easier to access at the time of cesarean section. So if you're thinking about removing it, probably easier to find. Posterior, people would argue that there's less scarring and potentially access with a posterior colpotomy. I'll get back to this because there's certain situations where this might be thought about. So that's being able to do a posterior colpotomy and perhaps remove that suture transvaginally. Another question that often comes up is, you know, what happens if we have a second trimester demise? So these can happen. You know, if you put in a cerclage before pregnancy is established, this is one of those risks. And there have been a number of cases in the literature that, you know, you can do successful evacuations up to about 18 weeks. You can pass dilators. You can use osmotic dilators to help. And a suction cannula or social forceps can be passed through. The alternatives to this, of course, are you can take the patient back, remove the cerclage laparoscopically. There have been some cases where I talked about or alluded to where you can do removal of the suture itself by a posterior colpotomy. So perhaps if you put that knot in that posterior, it might be a bit easier. I think the posterior is probably easier to access than the anterior just because there's, you know, the bladder isn't present and you don't have to, you know, go through and try to dissect the bladder away. And then the last option is hysterotomy. I mean, I think this is a little probably aggressive, and I think that it would, you know, increase the risk for uterine rupture. but this is something that can be done as well in order to successfully do an evacuation. So what do we do if we do have a successful, transabdominal cerclage, we do a C-section? What do we do with that that stitch afterwards? And this is a shout out to Dr. Hawkins at Langley Memorial Hospital. I'm not sure if she's on the line, but she did a great study a few years back, and they had I think this was done in Australia, and they actually looked at this exact question. So in short, cerclages that are left in place after a C-section are quite effective. As you can see, first pregnancy, second pregnancy, third pregnancy, the survival rates and the delivery rates above 34 weeks are quite favorable. So if you want, you can actually leave that cerclage in place if the patient is planning for another conception. So just to kind of highlight some of the points that I wanted to cover and summarize, I think that cervical insufficiency has profound maternal and neonatal consequences. I think that refractory cases of cervical insufficiency does require cervical intervention. And my feeling is that a laparoscopic abdominal cerclage is the answer to this. I think it's a superior technique for these refractory and rare cases. I think that it offers, improved outcomes, while also, for both neonates and also for the mother. And I think the big thing to take away is that, instead of the traditional vaginal approach where we're waiting for an established pregnancy, a laparoscopic or abdominal approach really requires you to place it preconception. And I think it is safer to place it preconception. Some of the questions I'd had after reviewing this topic, I think we should consider, the next step is to consider, hey, is a transabdominal cerclage or laparoscopic abdominal cerclage, will it ever be offered as first-line treatment for your first cervical insufficiency? I don't think we have enough data to support one or the other for sure. I think a vaginal approach is probably, or is definitely the gold standard right now, but the question that I had was, should there be a study to compare these two? And then the other question that came to mind when I looked at the data about removing the suture, it has been described that you can remove a suture transvaginally through a posterior colpotomy. I wonder if anyone would consider removing it near term to allow for a trial of labor. That's one of those things I'd be curious to know and pull the audience for that question. So with that, I'd like to open up the floor for any other questions that any of the audience members might have.
Thanks, Justin. Are there any questions from the audience at all?
So are these available for staff?
Yeah.
I don't think Dr. Grabowska is online. I was going to ask her the question you had. I can answer from my perspective about leaving a staple in versus visualizing just the proline suture. Merceline is definitely a lot easier to see, but we can still see proline without a problem. And I probably wouldn't leave something, just from my perspective, I probably just wouldn't leave something in the abdomen that doesn't have to be left in just for the sake of visualization when we can definitely see the proline suture.
Christy's here, and I agree.
Okay. Yeah, so thanks for that feedback. I mean, the clips themselves are usually titanium clips that we use for vessels and things like that, so they're safe. But it's good to hear that regardless of the material, that you guys can pick it up pretty easily. So I mean, for sure, I think if we don't have to leave anything behind, then why bother?
Justin, it's Kirsty. A couple questions. I think I got it. Appreciating that the Maverick study was abdominal, not laparoscopic. But one thing that did impress me in that study was that although the outcomes were better than cervical cerclage, there was still actually a very high, I think 20% incidence of delivery before 37 weeks, and still a reasonable, even with abdominal cerclage, like extreme preterm birth. That was in the Maverick study. Do you have a sense of what those numbers are with the prophylactic, the pre-pregnancy laparoscopic abdominal cerclage? I think you showed on one slide 3% mid-trimester delivery still, which is definitely a reduction in risk, but not population baseline.
Yeah, thanks for that question, Kirsty. I mean, I think that's a very good question. Unfortunately, there hasn't been a randomized controlled trial involving laparoscopic approach. Most have just been single center or grouped, retrospective studies that looked at it. But I mean, you are right. There are, there is still, despite placing these cerclages, there are some outcomes which are unfavorable. And I think, if we wanted 100% objective data, like we would have to plan for that randomized controlled trial where we did compare, specific laparoscopic approach versus other approaches.
Okay. Thank you for that. And just the thought that if BC is now going to start seeing more of these cases done, maybe making a gentle plea to our minimally invasive colleagues to think about providing that. But at least for me, it was eye-opening to see that it's still not a silver bullet and that there are still a reasonably high risk of preterm birth, which shouldn't be a reason not to do the procedure, but certainly should be something we incorporate into our counseling and management. One other thing, could you please explain what is a failed prophylactic cerclage? Is there a strict definition of that?
The definition that was used in the Maverick study, I mean, I think I know where you're coming from. The definition is not formally established anywhere. The essence of it is a previous vaginal cerclage that was placed for cervical insufficiency that did not, or that still led to a preterm birth. But I realize that there are more than one, or there is more than one definition out there that has been used in literature.
Yeah, I mean, I find that quite problematic because I think we all know there's a very big difference between well-placed prophylactic cerclage at 13 weeks that then culminates in a 24-week delivery, and the Hail Mary trying to pull together almost no cervical tissue on a 3-centimeter dilated cervix at 20 weeks that also culminates in a 24-week delivery. It is the same outcome, but I don't think they're the same patient.
Yeah, definitely agree. It's one of those things that I struggled with when looking even at our own guidelines in the SOGC about, how do we treat, like, what is the definition of a failed cerclage? But sorry, continue. I interrupted there.
No. This is a discussion. So Jason and any of the other MFMs or any of the other OBs, do you want to chime in? I would think that I would certainly refer to colleagues that do the preconception laparoscopic abdominal cerclage for somebody who fails the prophylactic cerclage, a well-placed prophylactic cerclage. But if it's the first-time event and it was a dilated cervix and there was a struggle to get the stitch and then they broke their membranes, I would think that the next pregnancy we should think about a prophylactic cerclage, although Justin made the good point that there isn't good data. What do other people think?
I completely agree, Kirsty. And James is sitting here with me and he agrees as well. And I just had one of these patients yesterday.
And I do actually think that we should start collecting these patients and we should maybe look at a research protocol because it is a really good question. And I think Justin raised the point, yes, there's other surgical implications for the patient, but maybe actually we should put the option of, especially when we see the preconception, of a preconception laparoscopic cerclage on the table. Maybe we should.
Hey, this is Neeraj. Yeah, great rounds, Justin. Just going off the heels of what Kirsty said, can you just comment on what it's like, because sometimes we get them when they are pregnant, these referrals. and they can be challenging. But can you comment specifically on that?
Yeah, of course. It is a very challenging procedure. I've been involved in a few of those. I think what happened, I mean, when you have a gravid uterus, everything, all that space that we learn to appreciate in minimally invasive surgery is gone. I mean, the uterus is bigger, it's closer to the camera. You're unable to manipulate the uterus very well because you can't put a manipulator into the uterus because of the pregnancy that's inside. It makes for a very, very challenging procedure for sure. And I mean, I think that's really why I wanted to emphasize on the point that if we're thinking about a transabdominal or laparoscopic abdominal cerclage, it really should be placed preconception because of those, the technical challenges and the increased risks. I wish I can show you a side-by-side kind of video of the two to compare. I mean, that'd probably be something I can add to the presentation for sure, but it is definitely a challenge.
Yeah, no, that's the thing. I think like the vessels get engorged quite quickly, even in early pregnancy. And even watching my own video, it's nerve-wracking watching, putting that stitch in around the uterine vessels. And it's even more so when you can barely manipulate the uterus and they're severely engorged. So that's, yeah, I would support the advocacy to send these patients preconceptually and perhaps considering them, yeah, as part of the counseling for doing so.
Thank you, Justin. That's great round. Just to add to that discussion, I think there's a few things to consider. Kirsty kind of hit the nail on the head of we have to consider these patients case by case of, like how many pregnancies do they have to lose before we start offering an abdominal cerclage, right? Like I've seen patients with a mid-trimester loss that was attributed to cervical incompetence, but they didn't have a cerclage placed. Then the next pregnancy, they didn't have a cerclage. They opted for a serial monitoring of their ultrasound length. All of a sudden, the cervix dilated. They had a rescue cerclage. That failed. So then, do you really want to just do a vaginal prophylactic cerclage for the third one, or do you just want to go ahead and do an abdominal cerclage? I think it's why it needs to be discussed sort of patient by patient. The other thing to consider is I've started sort of mentioning it to patients when they have a mid-trimester loss, like obviously not as it's happening, but sort of peri-loss counseling of like next time, or if you're going to get pregnant again, we should talk about doing, about your options before you get pregnant so that you have the best outcome. Because, yeah, I've done a few preconception cerclages, and they've all been successful. And I've done 2 cerclages in pregnancy, and the one I did at 6 weeks was successful. The one at 16 weeks failed, and it led to sort of a perioperative miscarriage, which is really sad. So, yeah, just thinking about those things. Thanks.
Any other comments or questions? All right, well, Justin, thank you very much for taking the time to speak to us today. Your video was an added bonus there. I enjoyed that. And please, everyone, remember to fill out your evaluations and the attendance sheet. And once again, thank you, and we'll see you all for next year's, next academic year's grand rounds. Take care, everyone.
Thank you.
Thanks, Justin.
Your call will be disconnected.